I'm dressed like this because I'm going to be crawling around the floor with the kids upstairs. That's why I'm in sweats today. So I felt like I had to tell you guys that. My name is Sandy Condon. I am a member of the Board of Directors of JDRF and also serve as the Vice President of Outreach. So some of you may have gotten phone calls from me last week telling you to come today. My son, his name is Neil. He's 17. He was diagnosed with type 1 when he was 16 months old. So we've had diabetes for about 16 years in my family. And I love this topic because it is a moving target. It's my pleasure to welcome you to the Symposium and to introduce our speaker on diabetes management in early childhood, Chasing the Moving Target, Deborah Holtorf. Deborah's been employed as a nurse practitioner at the Joslin for 11 years and provides direct care to children in diagnosed with diabetes, including diabetes management education and family support. Her particular area of interest is working with very young children with diabetes and their families. Deborah's practice also includes regular interface with school nurses regarding diabetes management in school setting and 504 planning. She was employed as a school nurse in Massachusetts for 15 years prior to returning to school for her MSN. Welcome, Deborah.
Thank you. So just to get a sense of who's here, how many of you have a very young child with diabetes in your lives? I obviously, yes. Hi. Parents, I can see. Grandparents? Anyone that has a different relationship?
School nurse.
School nurse, great. Welcome. We need all of you and love you dearly. I was trying to think about when I was asked to do this talk, what is different about the very young child and even who the very young child is. We know, and I'm going to show you just a couple of brief slides, that diabetes is being diagnosed at earlier ages. We don't know why, but there is a population now that seems to be expanding of children who are diagnosed somewhere between the ages of 18 months and 3, or kind of in that stage, some younger and certainly some older. Initially, when we started really looking at research around diabetes, we saw that there was a real peak of diagnosis in the adolescent age group. And clearly there was something about growth that might have been pushing that diagnosis in people that were going to get diabetes anyway. And perhaps there's something about growth that is making this other peak in the toddler years. But it's a challenging time to manage diabetes because of the very unique and wonderful personalities of our littlest children. Huh. Yes, perfect. So in terms of the epidemiology, in terms of where diabetes develops, who it develops in, we know that type 1 diabetes across the board has been increasing in incidence since the late 20th and certainly into the early 21st centuries. And during that time period, there has been a shift towards a younger age of diagnosis. And I'm not going to get into a lot of statistics, but just quickly, this is a study that is looking at children who are diagnosed with diabetes. And you can see that in the 0 to 4-year-old age group, you have a total of 14 on average per 100,000 person years. And what that's saying is really 1.4 per 1,000. And so that really, in looking at that very young population, that's a lot of diabetes. This shows some incidents in Colorado, and what they're looking at is the shift towards a greater rate of diagnosis. The upper one just happens to be, for all of Colorado, the younger for the Denver area. So again, you're looking at, over on the right side, you're looking at back in the 1970s, and now on the left side, you're looking at the rates that are in, now we're seeing in the early 2000s. So again, you can see that peak, you know, that rising peak that sort of speaks to increasing type 1 diabetes overall. And then the best slide I could find looking at the youth and when diabetes is diagnosed was from the big registry in Europe. And what that is showing is the rate of rise in the population groups, the top one being 10 to 14 years, middle one being 5 to 9 years, and the bottom line being 0 to 4. And on the left you have boys, on the right you have girls. But if you look at the rate of rise is greatest in the youngest group. So what are our goals? And why do we have different goals for very, very young children? You look at this, and any of you who have followed diabetes through the years with older kids, you sort of know what it's like to try to manage diabetes in adolescence when responsibilities are being shifted to the older person. You look at it and say, how on earth did anybody think up the fact that we should have a lower A1C in the older kids and a higher one in the younger ones when you've got more control of the younger ones? But clearly this is based on what risk is and the long-term risks. So what the ADA is saying is in the toddler, the preschooler, the child less than 6 years old, we're looking for an A1C that is less than 8.5% but greater than 7.5%. But if you look down at the very bottom, it says a lower goal is reasonable if it can be achieved without excessive hypoglycemia. And clearly now we have some tools that let us perhaps achieve lower targets in very young children without excessive hypoglycemia. Will you always be there? It's not, you won't. And it's not a report card or anything, but it's just sort of the guidelines. And what do we want to do in the toddler and preschooler? They have a developing brain, and we really want to avoid hypoglycemia. So they not only have this wonderful developing brain, they also have less ability to let us know when they are low. So we have safety concerns, clearly. And so that may be why it is difficult for some people to achieve targets. The International Society for Pediatric and Adolescent Diabetes recommends A1C less than 7.5% for all children. However, they have some caveats too, in which case they'll say children that are at greater risk simply because of who they are. It could be the 10-year-old that doesn't recognize lows, as well as the 2-year-old that doesn't recognize lows. Maybe those targets need to be higher. So they're just basing it a little, they state it a little bit differently. But again, it's not cut and dry. So what are the challenges? I think now that I'm looking at who's here and everything, you probably can tell me what the challenges are. But I was trying to think in terms of if I looked at the very young child compared to perhaps the preteen or the teenager, what are the different challenges of taking care of the very young child? Well, clearly we have unpredictable eating patterns. Toddlers will eat as much as an adult on some days, and they'll eat nothing on another day, and maybe just cheese for a few days. And so those are patterns that are so typical of the experimenting growing child. That's who they are. Unpredictable activity patterns. How many times does a little one not have a nap after lunch or suddenly settle down and sleep for 2 or 3 hours? That's really hard to manage when you're talking about managing diabetes. We already talked about hypoglycemic unawareness. They don't necessarily know how to recognize or communicate when they're low. Now, some are troopers and pick it up very quickly. I had a child who was nonverbal, sort of in the 15-month range, had a few words, but not terribly good at it yet. And he had taken to bringing his mother the meter when he didn't feel good, because he somehow connected that the meter made him feel better. And so again, this wonderful thinking that can go on. But clearly, if that same child had been involved in an active activity, that meter wouldn't have come to mom. She might have seen him lie down and start to fall asleep during the active activity or something like that, or, you know, but clearly awareness, even if it's there, disappears when a child's really active or distracted. Periods of rapid growth. And we all know what that's about. Kids grow not sort of in a nice linear, you know, sort of pattern. They grow in steps. And you actually grow taller in steps, so that you might go along at the same height over a period of several weeks and then suddenly wake up and be 1/4 of an inch taller. They've looked at that with growth studies. It's not that sort of steady progression. And what happens during a period of rapid growth is we have more growth hormone, and growth hormone tends to be something that makes a child or anyone more resistant to the insulin that they're getting. Susceptibility to communicable illness. Anyone who's sent a child off to their first year of preschool knows what that's about. You know, they're going to come home for a while with everything, give it to everybody else. But again, an illness can cause problems in either direction. Generally speaking, if a child is eating well during an illness, you're going to see increased insulin resistance, higher numbers. You know, the cold where they're eating, but, you know, they're just not quite right and maybe a little bit less active. Those numbers are going to go up. On the other hand, if they decide to throw up for 12 hours, what else are you going to see? You're going to see those numbers go down. So clearly, with illness, there's great variability. And then I think some of the more interesting parts of this age child is their evolving understanding of what diabetes is and how does it impact who they are. And then the challenge, given that that's going on, is how do we foster all their age-appropriate activities so that we don't neglect the total child for diabetes, because clearly we want the child to be the child and the child to be a child with diabetes, as opposed to the quote, diabetic child that we hear about. You know, that's something that we want to avoid. So unpredictable eating patterns. We'll sort of go through these quickly, and I'll just sort of tell you some of the things I thought of. If anybody wants to throw in something, we'll have a chance for question and answers in the end, but if you have anything that you want to add, please feel free. It's not a big group. So this is what we have available for insulin, and it's going to be a changing field as new insulins are being developed. But right now, what we have on the market are these very rapid acting insulin analogs. We have Lispro, which is Humalog, Aspart Novolog, glycine is Apidra. We still have regular insulin and NPH that we do use occasionally in children with diabetes. And then we have the very long-acting, which sort of we call peakless insulins. They aren't exactly peakless, but more or less peakless insulins. So that allows us to give insulin in different ways. We all have sort of basic needs. If insulin is needed to get carb into our cells so that we can burn it for energy, we need insulin when we're sleeping. And then clearly we need more insulin when we eat. If we lived in bubbles, we could figure out exactly what the right amount of insulin was, and we'd never have to correct a high blood sugar. But kids don't live in bubbles, nobody does. And so there are periods of greater activity, less activity, illness, all those things we talked about that are going to change insulin need throughout the day. So we do need to correct high blood sugars. So again, we need a little bit more for that. So for that background need, you're using either a pump or we're using the long-acting insulins. And then to achieve control when somebody eats, we're using the very rapid-acting insulins. If a child is not able, or it's very difficult to get insulin at lunchtime, and some of our children go to preschools where they're not giving insulin, a parent gets cold if they need it, then NPH can be a very nice insulin to sort of cover that lunchtime. Does it work as well as giving rapid-acting insulin every time? Probably not. But it does allow, again, for that developmental experience to be appropriate. So what are the plans that we use? And I think you'll find that most diabetes programs, if they're starting a child on insulin, are starting with what we call a basal bolus program, some sort of long-acting insulin in the background, and then covering meals. As the child requires more insulin, probably you're going to cover meals and snacks. So that becomes a lot of injections. As that starts to happen, maybe the decision is made to move to pump therapy so that each one of those bumps or boluses of insulin can be given by pressing a button rather than by giving an additional injection. And then we have the insulin plans that include NPH for whatever reason. Why an insulin pump? It does have the potential to provide insulin in a way that more closely resembles the way somebody would get insulin if they didn't have diabetes. Certainly more flexibility in the timing and the amount of food eaten, exercise, and sleep patterns. And it does let us do short-term dose modifications so that if you have an unexpected activity, if you have an illness, if you're traveling, we can make some changes on the fly. And I think all the kids will tell us fewer shots. So for the child where that's appropriate, it's a great tool. And I find that for families who have managed very young children using injection therapy, even though the pump may have additional tasks associated with it, the relief of being able to cope with the variable appetite is huge. So they'll say, look, I'm already checking the blood sugar 100 times a day. That's not going to be different on a pump. I'm already doing this, I'm already doing that. And so then for that family, the pump can be quite a relief. Why not use an insulin pump? Well, it's certainly not smart. It's a computer. And the data it gets is what it's going to act on, so it has to get regular and accurate data. So a lot of blood glucose data, somebody's got to be able to count the carbs, and that would be at home, but also if the child's in a school program or a daycare program, somebody's got to do it there. Or parents are wonderful about, packing little lunches and everything's sort of counted out. But there are some families that can't do that. And the ability to be able to sort of anticipate when activity is going to increase, decrease, when you might modify, is really an important skill to have. And then the pump only uses rapid-acting insulin, and it meets all the insulin needs by trickling it out to mimic the basal insulin and then allowing you to give the bump or bolus. But if it's not, insulin isn't being delivered because the infusion set has failed or the pump has failed, then the child runs out of insulin extremely quickly. So within 4 to 5 hours, you could be developing ketones. And again, there are families that are unable to be that watchful, and maybe that's not the best situation to have a child on a pump, because certainly we do have kids develop ketoacidosis on pumps, well, because the pump isn't working. And so it requires a lot of vigilance. So, unpredictable activity patterns, and I like this picture because this actually is one of my relatives, but we went to a children's museum for a quiet morning, except there was sock hockey, and that's what he did all morning. So that was unplanned, unpredictable activity that was fairly high activity. And what are we worried about? We're worried about hypoglycemia in a lot of those cases. It's the main risk factor when a child's active. Once we give insulin, we have no way to turn it off or limit it. And children, as we talked about, are unaware of their symptoms quite often. And the more they are focusing on something else, the more they will be unaware of their symptoms. It's as if it's almost impossible for the young mind to focus on how the body feels and the activity. And so we think that children are withholding this information. They don't know it. Now, older children sort of will tend to postpone a bit. They'll think, well, maybe I do feel a little bit funny, but I really want to finish this activity, whatever it is I'm doing. And that is so developmentally appropriate. They think in the moment. They really are not going to think ahead, even to the fact that they might not feel good in a half an hour or 15 minutes or 5. And so they may not tell you just because they want to get through something. And then the other reason that we worry about hypoglycemia is when young children exercise, they're much less apt to experience an adrenaline response. If you send an adolescent out on a basketball court and they are really focused on their game and they play like crazy, the blood sugar will be higher at the end of that game because they get this burst of adrenaline that goes right to the liver and says, fight or flight, give me sugar, which works for those of us that don't have diabetes and does not work for somebody, obviously, that does. So they get that burst of sugar, but that's much more likely to happen in the older child when they're doing a sport. However, outside of the exercise realm, when does it happen in a toddler? When do you get that release of adrenaline?
I get scared.
Scared, tantrum, that was the one I was thinking about, but definitely fright. So all those other reasons, sure. But at the end of it, tantrum, first of all, you want to make sure that the tantrum didn't happen because the child's low. But by the end of the tantrum, if you check a blood sugar, it's very apt to be up in the 300s. That's adrenaline. So think about the excitement stages of a toddler and how the blood sugar might react. So why does hypoglycemia happen? Probably, it could be any of these things that, if we were planning activity, maybe there was too little carbohydrate to sustain it. Maybe there was too much insulin on board in the pump when activity started. I think one of the hardest times to have exercise in a little one or even an older child is when you're starting the exercise and the blood sugar is high. So you want to correct it, and then they go out and play like crazy. That's the time they crash. That you've got that insulin, and it's just all of a sudden the body that wasn't utilizing it well really starts sucking it up, and so you get that crash. Unplanned activity, as we were talking about. And then because of the age group, I wanted to say, sort of make note of swimming and sledding. Because in those two sports, and you can think of other ones as well, ice hockey, you're doing two things. You're being very active, and you're also trying to keep your body warm. So it's sort of the double whammy. And in the first thing that happens in the winter is I get calls about, oh, she's been low all day, and the snow has just fallen, and they've been out sledding, and that's a huge one for bringing numbers down. And then we get calm for a while, and then the first warm days come around, and they're low. And swimming is another one that will do that. I'm sure you all have your favorites. Hyperglycemia, too little insulin given before, during, or after exercise. And I think sometimes we are so worried about the lows that we overdo it ahead of time and say, oh my gosh, they're going to be really active. I'm going to give an extra 15 grams of carb. And that activity isn't what we anticipated at all. And, we've just blew that one. And during exercise as well, the old thing we always taught for soccer, for the little ones, was just take some Gatorade and let them sip on it. Well, sipping on Gatorade may not be, our view of that may be quite different from the child's. What is a sip? So again, that kind of thing, we sort of just say, yes, it's a great idea, but monitor. An unplanned nap, that's a big one for waking up with a much higher number. and rainy days. I even have one family that's got a rainy day basal pattern in their pump, that the kids are active, they're outside a lot, and they get the rainy day, and all of a sudden those numbers are so high because they're so much more insulin resistant when they're not moving around. So what are our tools for activity patterns? I think you know what the tools are. She's holding one. Tons of blood sugar checking. She's in the Sierras, incidentally. So what can we do? Certainly with a pump, we've got a lot of options. We can program temporary basal rates. We can go down 10 to 30%. We can start for the child that's very active. That's really more typically in adolescence where we might start way ahead. We can continue it after the activity. Middle school students, there's a wonderful study of middle school students on sensors that when they exercised late in the afternoon, which would be typical, say they had basketball, that predicted a low way out, somewhere between 1 and 3 a.m. And so if that's what's going on, we could set a pattern where you kind of do the same thing in the evening, but then set a temporary basal that's lower after the child goes to bed for a few hours. So there are any number of things that we can do, provided that there's plenty of blood glucose data to work with. We can change the insulin to carb ratio for a meal or snack before exercise. A number of our young children have different ratios on a day when they have recess plus gym than a day when they just have recess, after lunch, say. We can disconnect the pump. For a number of sports, that's pretty appropriate, particularly for the young child who isn't going to have that burst of adrenaline. And maximum of 1 to 2 hours. If you're going to be up around the hour and a half, 2 hours, you might think about giving part of that basal insulin that they're going to miss ahead of time. And then in the summertime, or anytime, but consider if they're going to be disconnected from the pump for more than an hour or two a day, consider an untethered approach. If they're on a pump, you might want to give the basal insulin as Lantus if a child's just going to swim all day long and you don't have a pump that's waterproof. So that's another way, and that, incidentally, that approach didn't come from diabetes providers. It came from parents of young children. And all of a sudden, it was out there on the web, and then we learned about it. So, you know, you guys really know what you're doing. We want to estimate somewhere 5 to 15 grams of extra carb for every 30 minutes of vigorous activity. Again, the 5 to 15 depends on body weight, intensity of activity, and how much insulin the child is on per kilogram to begin with. We have some young children that make more insulin of their own than others. Might add fat or protein to help carbohydrate last a bit longer. So a little bit of peanut butter might help that carb last through an activity. And then on a rainy day, the other thing you might consider doing is if the child's not underweight, you might just take away a little bit of the carb and the fat. We don't want kids to feel that the diabetes dictates what they eat, but there are a lot of subtle things you can do with diet, particularly in this age group, that might help you out on some of those less active days. So hypoglycemic unawareness is a big problem, and clearly this child in this state would never know if they were low. And that's why parents of very young children check blood sugars all the time. And do we have an answer to that? Well, we have continuous glucose monitors, but that's a big decision too in terms of how it impinges on the child's life. So it becomes a very personal decision for the family and in conjunction with whoever their diabetes provider is as to whether this is something you want to do or not. Checking blood sugars a lot does really keep this child safe. So we want to increase monitoring during and after activity. We want to increase monitoring during episodes of illness. Consider glucose continuous monitoring in consultation with diabetes care providers. And again, that's a big decision because it's more than one site. If you have a child that really is having trouble getting their pump set in, then maybe that's not exactly the time that you want to introduce another thing to be inserted. On the other hand, you might have a child that's having really severe lows that you're just not keeping up with, and maybe it becomes a safety issue and you want to consider it. Periods of rapid growth. These, clearly, we've got to keep adequate insulin going in order for children to use carbohydrate so that they grow to their genetic potential. And we do see children who have very poor control grow very poorly. I think one of the first things all of you who are used to seeing your diabetes provider realizes one of the first things they look at is growth. And yes, we're looking to make sure that the child is staying on the curve that we expect. And if we see sudden drop-offs, one of our first worries is, are we giving enough insulin? Or is the child getting enough insulin? It may, depending on the age, vary as to what the reason is. Children who have frequent episodes of low blood sugar or whose caretakers are unusually frightened by hypoglycemia, they actually may gain excess weight. Because if you're always treating the insulin and you're so worried that you're always giving extra carb, then that child might be at risk for a greater weight gain than would be expected otherwise. Hormones that accompany rapid growth cause increased resistance. We talked about that. And what's interesting is that we all have some growth hormone, but clearly young children have more growth hormone than we adults do, and adolescents have even more than they do. But what you do with growth hormone is you pulse it in deep sleep. And so if you think about when the really little one sleeps deeply, it's usually kind of right after they go to sleep. That's the time when you could sort of pick them up, put them anywhere. Think about the adolescent. If any of you have adolescent children, when are they sleeping deeply? Just before you have to get them out of bed for school. So if you look at basal need, and we didn't really even know this until we started putting younger children on pumps and had more data, and now we've got continuous monitoring. The very young child has the greatest basal need usually after dinner through about midnight, and then it's variable, but I mean that's sort of the time when you see the need for the highest basal rates, whereas the adolescent, there's another hormone in there too for the adolescent, but you'll see the rising blood sugar and the need for more basal insulin somewhere after 3 a.m., 3 a.m. to 6 a.m., 3 a.m. to 7 a.m. So that's a shifting target there in terms of when you need to get that extra insulin in. Susceptibility to communicable illness. We do have a school nurse here, and whenever I look at this picture, the communicable illness I'm thinking of doesn't affect diabetes at all. You know, all those heads together, and I go, oh, I used to be a school nurse. So head lice, for those of you with the really young ones, is what I would think of. But they are spending time together. Those kids are breathing all over each other, and things pass around. And so their day-to-day activities, we want those activities to be what everyone else's are, you know, at that age and stage. And so it does put them into contact with a big variety of viral illnesses and some bacterial illnesses. And even mild viruses, even a mild cold, can increase insulin requirements. I'm not sure why exactly, other than this increased insulin resistance and perhaps decreased activity. But clearly there is a need for greater amounts of insulin with some illnesses. And then, as we were saying before, that GI bug with the vomiting and the diarrhea can result in very poor absorption of what the child is eating, and that therefore you get a drop in blood sugar. And as they get more dehydrated, you may get that combination of a drop in blood sugar and a rise in ketones. And so all of that takes a lot of management. And management of sick days is one of the other topics, which I hope you'll get a chance to go to if it's something that you have questions about. But clearly we're going to be monitoring ketones, we're going to be monitoring blood glucose a lot. And along with that, assessing how much fluid we're getting into a child and whether the carbs that they're eating are actually being absorbed. You may find that if a child has been sick for 48 hours with a gastrointestinal illness, that for 3 or 4 days afterwards, you feed them and they go low because they just, even still, are recovering and they aren't absorbing their carbs very well, and we have to sort of adjust carb ratios. So just be sure that you're very aware and have a copy and understand what the sick day protocol is. Clearly, the first few times you go through it, you're going to want to be on the phone with your provider and getting advice. But over time, you'll be more used to sort of what the baseline is for a usual type of viral illness, perhaps. Make sure that you've got a supply of something to monitor ketones with. If you can, during an illness, it is certainly better to monitor blood ketones because you get a real-time result and you know when you've made progress. Urine ketones, once you have them, can persist up to 24 hours. So it's really hard to know if you're getting anywhere. However, many insurances are not covering the ketone strips and the blood ketone strips, and they are really expensive. So it's not something that everybody can do all the time. I try to sort of make sure somebody's got a small supply for an illness, and then, otherwise maybe use the urine strips. Again, with a very young child, sometimes we can justify the strips just because they don't pee on command. And the sicker they get, the less apt they were able to do that anyway. So, and then talk about what mini glucagon injections might look like. And you come from a variety of diabetes practices, but one of the things that we do is use a very tiny amount of glucagon for the child that is not able to eat and is vomiting, might have diarrhea. And often that can keep that blood sugar high enough so that we don't have to send to the hospital. And it becomes a nice thing to get through a very short illness with that, a child's vomiting, or so that may help. So how does diabetes impact identity? Let's look at who an infant or toddler is. Clearly, they're developing an understanding of words and routines. Routines are incredibly important. And the routine of blood glucose monitoring, the routine of getting an insulin injection, the routine of having their pump programmed and getting insulin become very important to them. And I think most young children do extremely well with these routines. Probably the first one they adapt to is the check. And within a week or so, many, many young children are just kind of holding out their finger. And they're terrific about that, unless they're overtired or something. There's always going to be a time when they're not, but for the most part. And injections maybe takes a little longer, but they get used to it and it becomes part of their routine. Pump site changes, a lot of production goes on with a pump site change. They seem scary at first, but if you can sort of maintain this sort of even disposition about the whole thing, you can make them more routine. They do reflect the caretaker's emotions and expressions. So I think the whole business of staying calm and matter of fact about how these chores are carried out is so important. It has to happen. We never had a question about whether you get insulin or not. But if you can sort of make it as matter of fact as any other chore that you do with this child, changing a diaper, whatever it is, it has to happen. And just staying very unemotional in the face of the child's emotion. That's hard to do. I mean, particularly at diagnosis when your child's crying and they hate it, and or what, and then you're trying to sort of stay absolutely calm, and you're not feeling that way. But it really helps. And so we find that the youngest children incorporate the diabetes management into their daily routine very nicely, far better perhaps than their older compatriots. Preschool has a lot of magical thinking. A child that's diagnosed, or even, I think, comes to look at their diabetes again when they're 3 or 5, between 3 or 5, I think to keep in mind that they don't know what it means to have something that isn't going away, no matter what we tell them. It just isn't part of their whole conceptual framework. So we are telling them the truth, that this is something we're going to need to do. But you may have a child burst into tears at the age of 4 that's had diabetes for several years because it didn't go away. And maybe they had a date for that, my birthday or whatever. So remember, they do think magically. And again, those are horrible moments for parents. They just hurt, because you've got a very distressed child. The preschooler also may explore a way of getting attention through physical complaint. So you have to keep that in mind as a normal developmental stage, that the tummy aches, I feel low, maybe just an experimentation with how to control the world. And they do begin to have some feelings of guilt. And so you have to be very careful with children that they don't think that the diabetes is something that they did, something that's caused by what they think. And we often see this in siblings of children with diabetes, that the child that's in this stage, the sibling may think that they did it, because what sibling is always pleased with their sibling, so they do have those thoughts, and they do wish evil on their sister or brother occasionally. And so they may be the ones that are feeling very guilty that maybe they caused the diabetes. School age, continued magical thinking, beginning awareness of their own appearance and abilities, understanding of contagion may generalize. So those are the teasing years sometimes, where, diabetes, and all of a sudden it's diabetes diarrhea or diabetes dia, and you get this icky stuff. And that's a very good age, though, to actually make a presentation. They're very susceptible to learning to be kind, to learning about something, and that often will just completely get rid of that age teasing, is just to give knowledge and do it at a very obviously age-appropriate way. They're beginning to see themselves based on approval or disapproval, and so they're beginning to see the parent's expression when the blood sugar is higher than they expected, perhaps. And so even though we're very good at, not saying a number is bad or good, we've gotten over that, they're high, they're low, but the face falls. Especially you're frustrated. Where did it come from? I don't know, And they're very good at perceiving that. And so the only thing I wanted to talk about quickly is that is the age where we start to see fabrication. So that by the time a child is 7 or so, if they've had diabetes for a long time, it's like, you're right there, but you'll say, could you check your blood sugar and just tell me what it is? And very quickly the child learns that they want to please you. Your face looks a lot better if it's 100 than if it's 300. And very naturally and very developmentally, it's appropriate. They start to please you by giving you a good number. They don't see tomorrow. It's just not part of their view. It's not in them developmentally. And so I think that's something you have to sort of take without a lot of fury and sort of calm it down and sort of explore it and realize that maybe I need to see all those numbers. That just gets rid of it. It's not, it's not a problem anymore because you're seeing the numbers. But we do see a lot of fabrication, and it's tough. And again, they're seeing, they may begin to avoid a peer who's thought of as being different because they're beginning to get that suspicion. And usually it's not the child with diabetes, but that is something to sort of keep in mind. And then I don't think we need to go, our talk really doesn't go into this age, but if you want to talk about where the fabrication really happens, that's where it's really happening. They just really know they want things to be right. And so I've had kids simply look at me and say it was easier to say it was 120. And understand where they are developmentally. They do not see the future. And then let's just quickly go over what are the age-appropriate developmental experiences. We want our kids to be in playgroups. We want them to be in preschool, kindergarten. We want them to be in group physical activities. It's good for them. And then over time, perhaps diabetes camps. So all of these are things that we need to plan for. More and more, we're getting daycares that are willing now to give insulin. We've had some very good success with that. Not so much the private ones, but the ones that are under Office for Children in Massachusetts. They're governed by a different set of regulations than the schools are. So actually, a non-licensed provider can give insulin in a daycare, whereas they can't in a school. I don't want to go over, because I want some chance for you to sort of bring up observations or ask questions. So let's kind of stop here and see what it is that we haven't talked about that you'd like to talk about, or what you have to add.
Could you say that again as far as a nursery school cannot give the insulin, but a daycare provider could?
The question was, can a nursery school give insulin to a child? I think if it's a licensed daycare facility, then they are under the rules of Office for Children. And the rules are quite spelled out as to what education needs to go on. But a non-licensed person, at least in Massachusetts, can be taught. If it's a preschool that's associated with a public school setting, then they're under the education and Mass Department of Public Health regulations that are different, and a non-licensed person cannot give insulin. Now, in terms of a private or an unlicensed daycare, I don't know what those regulations are. I don't know how they fit, but that's just where I...
Yeah, I'm a licensed provider, and that's why I'm here.
Mm-hmm.
The child in my daycare just came, got diagnosed. So I want to learn about it. I have the VNA nurse come in, but she's only limited. So I didn't know that there was a protocol for me that
I think you have to contact Office for Children and see what the protocol is. The visiting nurse can teach you, do a lot of diabetes education. I think if you are actually going to give an injection, from what I understand, and again, I'm not an expert in this, you have to be taught by a physician or a nurse practitioner.
Yeah, it was.
Yeah,
Okay.
so, I think that's where the difference is.
Okay.
Yes?
I noticed that my daughter goes very low after a bath. Is that similar to the swimming, trying to keep the body warm, or is that some different mechanism?
Okay, so this is a child that goes low after a bath.
Very quickly.
Yeah, well, I think what happens in warm water, and we see this in hot tubs, even in adults, is you expand the blood vessels close to the skin. And so what that does, if you've just given insulin, is it causes the body to absorb it very quickly. And so yes, there is a mechanism why that might be happening. And you might try just giving the bath before they get their dinner insulin to see if there's much of a difference, because it really is an increased absorption and more rapid absorption.
When you got
about making a presentation. Could you just, I know it's maybe a little bit older, but like what age? Would you go into the kids' kindergarten class and as the parent kind of explain, or would you do it every year, or how have you seen it work well?
Okay, so asking about making a presentation in school. I think it is worth doing at the kindergarten level. Whether you do it every year, I don't know if that's necessary. It sort of may depend on your school system, and a lot of these kids just sort of proceed on and together, and so that they're pretty well informed. But I know that we have at Joslin an outline for a kindergarten presentation that talks about the language to use that one of our child life people did a while ago that's available. And you can probably look it up anywhere too to see what language you use and what you're trying to say. The other time you might want to do a brief presentation would be a child that hasn't been on a pump, that goes on a pump, because now you've got this sort of visual, and also you've got very curious kids. And I very rarely, almost never, have had a child play with their own pump, but a friend, so you really want to make sure that kids understand what that is and why the child's wearing it and the fact that they don't touch it.
Can I just say something to her? Because my daughter's in kindergarten this year, and it was her first year at school all day long. But her teacher and I work very closely with, there's 20 other kids in the class. And she actually said to me in the end of October if I could come in and read a book about it, because Kate was getting asked by a lot of other kids, what is that? And she wears like an insulin pump. So just to take that scary, what is that on that girl's body type of thing out of it. And it worked wonderfully. And we've had no problems whatsoever. Everybody's very open to her, and I might do that again next year too. But it's kind of with the teacher and how the school feel about it, but they were all very open, just saying.
Just to add to that, we also did that at the beginning of the year, and we engaged the teachers and the PE, the librarian, the whole community, and we added to the same experience that you just mentioned, we added a letter to the parents. So in case your child comes home saying that, Arturo or son's name has a boo-boo or has blood, because they will see him being checked. So know that this is what's happening. So we kind of nipped it in the bud and then followed up with the show and tell. There's several children's books.
I have a great one.
Yeah, I mean, there are some that are wonderful. Some I read them because some of them say things that we would prefer they didn't say.
And then the teachers created a little kind of a show and tell about fruit and sugar and what is healthy to eat and not to eat. So they kind of worked on that, built on that. From the diabetes, they kind of transitioned into some kind of, some teaching tools.
Yeah, I mean, I would love it if there were school-wide nutrition initiatives. I don't want to see an initiative or a child being singled out. And often we have still school nurses that call us and say, do you believe what so-and-so brought for their snack? And maybe this is a family where they're terrified the child won't eat at school. And so the treat for the day is what comes for a kindergarten snack. And so there may be all sorts of, but I always say, is there a school initiative? Can we talk about healthy snacking for everybody? Because I think that's really what we're aiming at. Anything else? I think it is 5 of 11, so I think we're supposed to move.
Yes.
Okay.
Thank you.
And I'll be around at lunch if anybody has any questions.